Hello, my name is Erick Fonseca, and this is my presentation on intravenous access device cleanliness for nursing 451. We're going to start with background. So according to the CDC, there is an average of 130 million total emergency department visits per year and an average of 60,000 visits for each emergency department each year, average, with a large percentage reaching over 100,000 yearly visits for the busy ERs. Around 50% of those patients who enter the emergency department receive IV therapy, and 100% are required to have an IV upon admission. Some patients already arrive with central lines, whether it be tunneled, non-tunneled, PICC lines, and that sort of intravenous access. Although a 46% decrease in CLABSI, which is central line acquired bloodstream infection, has occurred in hospitals across the US from 2008 to 2013. An estimated 30,000 intravenous bloodstream related infections still have occurred, which is down from what it used to be, but it's still very present. Issue identification. The issue is awareness, poor use of alcohol, prep hubs on saline / HEP blocks on IVs, as well as PICC and central line ports. And by that, I mean the luer lock connector. So a lot of patients do not come in with the caps on the say the PICC line, and a lot of patients in the emergency department don't have those little caps when their IV is not in use or they don't have IV fluids running. Due to the frequency and pace of a busy emergency department, hubs are kept off, and this creates poor habits of cleaning the port with alcohol pads before administering intravenous therapy, any sort of IV medication. So this kind of sets up for a bad habit to kind of not keep it clean. Stakeholder involvement. So this really requires the involvement of everyone. The nurse is administering medication because they're directly working with the IV or central lines management to create awareness and to kind of create some emphasis on infection prevention. Also availability of IV central line port protection or cleaning devices, such as the caps. I know a lot of emergency departments don't have those and are not required by some hospitals. Occurrence of central line associated infections was around 49,000 per year prior to 2001. After that, it was decreased once there was a lot of awareness and interventions done. The mortality rate from these infections is 12 to 25%, and still to this day there are 23,000 yearly hospitalizations due to intravenous related infections, which has decreased since 2001, but as I said, it's still very prevalent. Quality variance. IV and central line associated bacterial infections occur outside of the ICU, in homes, facilities, and outpatient centers. ICU, because a lot of patients that tend to have central lines, which is a catheter that's very, very close to the heart, if not in the heart. So infection related to that has a lot of potential to be dangerous, as opposed to a peripheral inserted IV, which is only temporary. Compliance by healthcare staff of intravenous tubing disinfection, caps for the luer lock, and hand washing is only 25 to 50%. So that's kind of what's missing, is that only about 50% of nurses are actually washing their hands and cleaning their hands every single time they come in contact with the patient. So that adds to the problem of these infections and not using the caps. Root cause analysis. So since the introduction of needleless IV tubing, the Luer lock, prior to this practice, needles had to be replaced every time. So which means there would be a clean device, sterile device to administer medications, as opposed to now, where the Luer lock is exposed if it's not capped, which can contain bacteria and then thus injected into the bloodstream. Practice of looping. Many times when a patient is disconnected, so they need to use a restroom or what have you, nurses would loop it, so they would connect the tubing to itself and maybe not clean it. So then that traps bacteria within the tubing and then into the bloodstream when it's reconnected. Lack of emphasis on infection control. A lot of this has to do with also management, maybe not pushing enough to make this, to make nurses aware, and lack of alcohol prepped caps, which is something that is also very common. A lot of places don't have that or require it. Stakeholders, physicians, they use central lines many times to administer certain type of medications, especially in the ICU. Charge nurse supervisor, they need to be kind of on top of it to set up courses or required annual courses to refresh all the nurses and remind them that they need to clean the hubs before administering medication. And then, of course, the RN, who is always directly working with medications and every IV or central catheter, hooking up and disconnecting tubing and syringes to administer medication. So RNs have a lot of responsibility to hold up on the cleanliness, and patient and family to receive safe care, and also to provide feedback. They'll also be the ones that obviously let us know if they become ill because of intravenous therapy related infection. Solution: increased awareness of infection potential for intravenous access devices such as peripheral IVs, PICC lines, central lines, with a goal to continue to reduce the number of hospitalizations and incidences of intravenous device related infections. So there needs to be increased awareness of it. There needs to be an increase in hand hygiene practice. Also equipment like alcohol prepped caps and pads to clean and create a habit of it. There's also what's called the Pdsa bundle, which is education for the nurses and physicians, having equipment like carts with all the supplies for central line insertions and keeping it clean as well. Using a checklist during insertion to make sure that no step is missed and the procedure is clean. Also stopping if anything is missing or has not been done right. And also continuously assessing the lines, IVs, or central lines. Also include the use of providone iodine gauze hub covers, 70% ethanol for daily disinfection of hubs, and decontamination of hubs with chlorhexidine or providone iodine solutions. Solution implementation. So this would be the set timeline for how it would go, the plan to kind of implement these solutions. So it would be, at the beginning, it would be the gathering evidence-based practice, introducing it to the stakeholders, basically everyone involved, introducing the Pdsa bundles to the staff, and develop a plan to proceed with practicing all the evidence-based practice and the plan. From there, once it's all introduced and in place and in its beginning stages, then there would be continuous education, there'd be more training, and then supervision of all the whole process to make sure it's being done right, especially in the beginning. After that, there'd be observation of proper procedure performance. So make sure that everything is going as it should, that it's going as planned. Then a 30-day review of the program effectiveness. So this would be kind of a evaluation of how things are going, any changes that need to be made, any improvements that need to be made, anything that needs to be brought up. Then it is a 90-day review, which is more continuous evaluation, basically evaluation of any changes that were made, any practices. Then, as time goes on towards the end of the year, there would be a comparison of the results. So what difference is there now towards the end of the year than there was in the beginning? And basically seeing if all the actions, interventions, all the planning has made any changes or improvements. And then about a year later, then there will be the program evaluation in general to see if the whole program is effective and reaching its goals as it was intended. Analysis. Data must be collected by infection control or any infection control committee from the hospital, and continuous collaboration between emergency department, since they will be usually the first to see a patient come in. They will be the ones starting an IV, and many times that's where the patients will also have a central line placed a lot of the time before they go up to the floor. And then also the rest of the unit's management team to kind of correlate and bring about the results, to kind of bring it all together and see the data of whether it's working or not. Data must include period of time, staff, unit, nurse documentation regarding care for the intravenous therapy device, whether it be IV or any other longer lasting intravenous device. Assessment by management by rounding to see if all the, say, bundle, the Pdsa bundle, or all the education is actually being followed and done at the hospital, such as cleaning before administering medication. Also, the use of caps, make sure that the IVs that are not in use, that are locked, have a cap on them. Also, a survey of the staff themselves to determine if they are following it all the time, or if they're following it some of the time or most of the time. Basically seeing their feedback as far as how they feel they are following the procedures that have been implemented. Next steps. After that, it would be collect the data for the first year, obviously to see if this whole planning and intervening has had any effect or any improvement in the infections. Also keep track of the results, and then submit them to CDC's database for reevaluation and continuous, comparison to previous data of the number of infections, say, in that hospital or in general for the country. Also continue to meet for strategic improvement planning and evaluations throughout the year. So emergency department, make sure that the whole Pdsa bundle and the IV therapy cleaning starts there before they go up, and it continues on with all the other units. So basically continue to follow up and make sure that everything is still going on and hasn't kind of deviated from the intended practice. Also hold annual intravenous infection control refresher courses to emphasize infection prevention. So basically, every year, have a little reminder, like to prevent, again, from deviating from the initial practice of preventing infection. So all the cleaning, how to clean, how often to clean, when to change alcohol prep caps, how often to restart IVs to prevent infections, and also to reset goals every year to improve from the previous. So continually strive to improve from the year before. And that concludes my presentation. Thank you for watching.